So good morning, everyone. So this is the ground runs for today. We had a very special guest this time, as Dr. Mishra, and she's actually a faculty in Sinopana Stroke Attendance at Maimonides Medical Center. So Dr. Mishra is the Associate Stroke Director and Director of Stroke Education in the Department of Neurology. She's mainly working at Maimonides Medical Center. She, as an interesting fact, she's Canadian. I just know about this, and she completed her residency in the Memorial University of Newfoundland in Canada. She completed her vascular fellowship in Northwell here in New York. So she has been working for us for, let's say, like a few years, and she's a very active member of our community. She's been involved in research, and she has some active researchers in some grants. And this is one of our most beloved attendees, and she agreed to give us an update on this stroke treatment in the acute phase. So I'm gonna give all this spotlight to Dr. Mishra.
Good morning. Can you guys hear me? Okay. Good morning, everyone. Thank you, Sergio, for that very nice introduction. So let me just share my screen. One second. Sorry, just my computer is acting up a little bit. Can you see my screen now? Okay.
Yes, we can see it.
Okay, perfect. All right. So I wanted to talk about thrombolytics in acute ischemic stroke, and just trying to really keep to what are the guidelines. Are there any updates on when you give TPA, when you don't, if you're suspecting acute ischemic stroke, and not so much focused on, very detailed trials, but I do have some information about trials. Don't have any disclosures. So we're going to just touch base about the background, indications, contraindications of Alteplase, and just focus on a couple of areas which are sort of gray zones, talk about what's new, and talk a little bit about IV TNK or Tenecteplase, which is another thrombolytic. So Alteplase, and I am going to be using tPA in kind of lieu of Alteplase. And then when I switch to TNK, I'll make sure I kind of distinguish the two. So Alteplase was approved by the FDA back in '96. There was the NINDS TPA trial, which was the landmark trial in 1995, and subsequently became a standard of treatment for all patients who presented with symptoms of acute stroke within 3 hours from the last known well, and then selected patients within 3 to 4.5 hours from last known well. So just wanted to mention a little bit about the TPA study. It was back in '95. It was published in New England Journal of Medicine in December '95. And just, again, this is a lot of information, but just pretty much what it says is these patients, what they did was they took patients who were having stroke. They gave them TPA versus placebo. They randomized them within 3 hours from their last known well. And there was two things they looked at. The first thing was to see if the patient's NI stroke scale improved by about 4 points at least, or the symptoms completely resolved at 24 hours. And the other thing was disability and functional outcomes at 3 months. So looking at the first thing in terms of improvement at 24 hours, they did see there was more improvement, 47 versus 39% in patients who had TPA versus placebo, but this was not statistically significant. Secondly, in terms of the outcomes, there's multiple outcomes, but I'm just going to focus on NI-8 stroke scale and MRS. So they looked at favorable modified ranking scale, which is a way to look at disability for stroke patients. One or less was considered favorable. 0 means they're completely recovered from their stroke, back to their functional status. 1 means they have very mild residual impairment, but they're still able to function, to do their ADLs. So that was considered favorable, and they saw 39% versus 26% for placebo. And NI stroke scale 1 or less, again, which as you can see is very mild, which means that patients pretty much resolved or they had very minimal deficits. And again, they saw 31% of the group in TPA group versus 20% placebo had this favorable NIH stroke scale. The symptom SICH means symptomatic intracranial hemorrhage, and that was about 6.4% within 36 hours after TPA versus, of course, much less, 0.6% placebo. So despite increased incidence of the symptomatic ICH, treatment with IV TPA within 3 hours of onset of ischemic stroke improved clinical outcome at 3 months. So this was, our landmark trial. Subsequently, there was more and more literature, more data showing that, yes, Alteplase does improve functional outcomes, and it started becoming, standard of care. ECAS-3, and there's been lots of studies. I'm not going to go into all the various details, but ECAS-3 was another big study, which was a European study, where they did thrombolysis again with Alteplase, and they took the time window from 3 to 4.5 hours. So far, we were only giving TP up to 3 hours, but then extended the window to 4.5 hours. And this was a European study. So it showed that IV TP again improved neurological outcomes within 4.5 hours. However, even because it was a European study, if you look at the FDA indication for Alteplase, it is not FDA approved for this extended window. So it's only approved for within 3 hours by FDA. However, as per American Stroke Association, American Heart Association guidelines, it is a standard of care for patients within that extended window. And it is practically what we do. We do give TPA within the extended window to our patients. The dosage is standard 0.9 milligram per kg. And you give 10% of total dose as a bolus over a minute and the remainder over 60 minutes. I just want to talk about a little bit about, are the stroke volumes of Maimonides and how much TPA we give. So we're a comprehensive stroke center, and we see almost 1,000 stroke patients a year. In terms of TPA, these are numbers from the last few years, so kind of range between 60 to 70. And I think our numbers this year are going to be similar. So it is just the point was there's a lot of strokes we see at Maimonides, at Kings County, downstate. And TPA, of course, you can see the numbers are very small compared to the volumes. And that is something else to kind of talk about, patients coming in much later than the time window, but it is a standard of care. So indications for IV TPA, I think we all know this, but main thing that is said is that we need to exclude any kind of bleeding. So pretty much exclude intracranial hemorrhage. And before you start treatment for TPA, you want to initiate it as soon as possible, but within 3 hours after symptom onset. And this is as per the American Stroke Association, Heart Association. So I'm going to talk a lot about guidelines. So just wanted to show you what the AHA, ASA, what's their recommendation, what does it mean? So there's class and level. 1 is pretty much the strongest, and ideally that's what you want to have in a guideline if you're doing that as your standard of care. So class 1 is strong. And then 2 is sort of in the middle, like the benefit is maybe outweighs the risk. There's a 2A and a 2B, moderate and weak. 3 means either no benefit or harm. So it's really important to also know this category, because of course it's nice to know this, but it's also important to know what is harming, what can possibly harm your patient. And then there's level of evidence. A is pretty much, they have more than one randomized control trial. So just looking at the indications, so we're going to go through some indications first. And if there's any questions, please feel free to ask. So indication-wise, IV Alteplase within 3 hours is equally recommended for patients less than 80 and 80 years old. This is important because we still see people who are coming within 3 hours over 80. There's sometimes still confusion, are they a candidate for TPA or not? But it is a class 1A recommendation, which is the highest level there is, that patients who are coming even who are older than 80, they still qualify for TPA. And the other thing is, sometimes we worry about severe stroke, which generally means NIH stroke scale more than 25. So do we give it to these patients? Do we not? So it is indicated within 3 hours from symptom onset of ischemic stroke for patients with severe stroke. There is increased risk of hemorrhagic transformation conversion. However, there's still proven benefit. Thus, it is still a class 1A recommendation. For patients with mild but disabling stroke symptoms, it is also recommended to give IV TPA within 3 hours. So I'm going to talk about mild strokes a lot in a little bit. So we will not talk about that now. We'll get that in a few seconds. Okay. All right. So IV Alteplase is recommended for selected patients who can be treated within 3 to 4.5 hours. So this is what I was mentioning. This is based on the ECAS-3 trial and subsequent studies. And again, this is AHA-ASA endorsed, but not FDA approved. If there are patients who are in this extended window, and they are, again, less than 80, they do not have a history of diabetes and prior stroke. If their NIH is 25 or less, they're not taking any oral anticoagulants, and they do not have ischemic stroke more than 1/3 of the MCA, then again, it is recommended. It's still a class 1. And I'm just mentioning all this so we can talk about some of the nitty-gritty in a little bit. Further looking at the indications, it is said that the blood pressure should be less than 185 or 110 before administering TPA. Blood glucose should be less than 50. Both are class 1A. One of the other questions that arises is sometimes these patients are taking antiplatelets. Should we give them TPA? So again, class 1A, that it is recommended to give TPA to patients who are taking antiplatelets, single or dual. Sometimes we have patients on aspirin Plavix, aspirin and Brilinta for coronary artery disease, for maybe a stent. So again, that is not a contraindication. One of the other, which is interesting, is that patients who are have renal disease, they're on dialysis. What happens then? So it is recommended to give TPA to patients who have renal disease on dialysis if they have a normal PTT. If they do have elevated PTT, they might have elevated risk of hemorrhagic transformation. So it is something to really discuss with the patient or the family. However, this is still a class 1 recommendation. I wanted to bring this up because personally, sometimes I might not pay as much attention. Sometimes, somebody is on dialysis or not. It is not something we talk about as much. So I just wanted to make sure everybody's aware that if you do have a patient on dialysis, please make sure you take a look at their PTT. If it's elevated, think about the bleeding risk as well. So that are some of the indications. And these are really just the class 1A. We're not going into the 2 yet. We'll go to the 3, the harm first, because again, do no harm. So we want to make sure we are aware of the ones that can harm the patient. And when we say harm, most of these mean risk of intracranial hemorrhage. Sometimes they mean risk of cardiac complications. So this is again from the guidelines. No head trauma or prior stroke in the previous 3 months. So coming to head trauma, so it is within the 3 months, but also acute head trauma. So if the patient, sometimes we have people who fell down, and they fell down because they had stroke-like symptoms. But if they have very significant head trauma, then it is not recommended. Now, they don't really define what that means, but generally if there is a fracture on CT, if there was loss of consciousness, if you can see overt signs of trauma, then those are the times that you would not want to give TPA. Stroke, so recent stroke in the previous 3 months is also a contraindication. In terms of GI bleed, things have changed a little bit. In the past, we used to always say GI and GU bleed in the last 21 days, absolutely no TPA. But currently, no GI bleed in the last 21 days. Or if they have a structural GI malignancy. So we do get patients with, say, colon cancer or some kind of mass, and they come in with stroke-like symptoms, it is contraindicated. I'll talk about GU bleed in a couple of minutes. No history of intracranial and spinal surgery in the previous 3 months. I think we all know this. No history of previous ICH. Of course, no evidence of acute ICH, acute subarachnoid. Sometimes we don't know if the patient has a subarachnoid. Their CT might be negative if they are very early in their course. But if there is suspicion the patient has like definitely or high suspicion they have subarachnoid hemorrhage, then again, that would be a contraindication, and it would be recommended to actually do the workup to find out if the patient has subarachnoid before giving them TPA. Infective endocarditis is also a contraindication because giving TPA can increase risk of intracranial hemorrhage, as these patients tend to form mycotic aneurysms, which are small aneurysms in the distal arteries generally, which can rupture and cause a bleed. If there is suspicion or confirmed aortic arch dissection, because again, giving TPA can cause rupture and of course death. If they do have an intraaxial intracranial neoplasm, so that's a contraindication. In terms of extraaxial is I'll talk about in a second, but it's kind of in the middle. It's like maybe you can give it, and that would be something like a meningioma, which we see very commonly. But if they have an intraaxial intracranial, like a GBM, lymphoma, those kind of tumors, we would not give them TPA because of the risk of intracranial hemorrhage. Other things, so again, taking oral anticoagulants. So if they haven't taken a direct oral anticoagulant for more than 48 hours, or if their pertinent lab tests are normal, only then you can give TPA. So what does the pertinent lab test mean? That's a bit, we're not clear, because it means like INR, PT, PTT. But again, the DOACs we use, these measures are not a direct indicator really. So ideally you want to get a factor 10A, you want to check thrombin level, but that's not available in the ER. So this is something that only if you're able to get the test and you're sure that despite taking oral anticoagulant, the patient has completely normal coagulation profile, only then you would give TPA. So the reality of the situation is if we know that the patient has taken a DOAC in the last 48 hours, regardless of what their INR coag show, we would not give them TPA. If warfarin is being taken, the INR goal is less than 1.7. The platelet count less than 100,000. Again, just as a reminder, if we do see a patient in the ER, we think they're having a stroke, we do not wait till the platelet count is back. We can start the TPA, and then if, say, you do get the platelet count back saying less than 100, then you would stop the TPA. Unless there's an obvious history of it, like it's somebody with a known thrombocytopenia, they're on some medications which we know causes it, then you might want to wait. But the general practice is to just start the TPA, and then, if you get the labs which are normal, then you stop it. And the PT levels are high. Those are also contraindications. A couple of things that the guidelines have started mentioning is that do not administer aspirin within 90 minutes after start of IV TPA, just because of the increased risk of bleeding, again, intracranial hemorrhage as well. And this is something that was not mentioned previously, but is being mentioned. It is interesting because right now we have the 24-hour protocol for everywhere that after you give TPA, you do not give any blood thinners in any form for at least 24 hours, which is what came from the original NINDS trial. That's how they ran it. So we continue to do things like that. But the fact that the AHAS is now saying that at least for the 90 minutes, do not give aspirin, I think kind of as an indicator that maybe in the future, we will not have this protocol where we do have to wait for 24 hours. Maybe it'll be much earlier. And then the other thing they mentioned is the D2, B2A, and 3A inhibitors should not be given at the same time as TPA. So sometimes we have a patient with, severe athro, they got their TPA, they're going in for a thrombectomy, the neurointerventionist is there, they're trying to really remove that clot. They have like bad athro. They want to use a G2B3 inhibitor, but they've also gotten TPA. So that would be a contraindication, again, because of a high risk of bleeding. So those are harms. I think that's very important to know the harms one, because you definitely do not want to harm your patient. Interestingly, the contraindications for TPA are a little bit different on the package for the medication. I always find it interesting to see how things change, and I just want to kind of, if anybody's interested, share this. So their things are same thing: no bleeding, no recent surgeries, presence of any conditions that might increase the risk of bleeding, so AVMs, aneurysm, neoplasm. And this is interesting that they say current severe uncontrolled hypertension, but they do not define it. So the guidelines still say 185 or 110, so that's where we go to. But the company is saying that it could be uncontrolled severe. So that's interesting. It's a bit like, very vague. So I think we have to stick to the guidelines. But that makes me personally think that maybe in the future we will not have such strict blood pressure guidelines, because we do know that patients say they have a LVO, large vessel occlusion, or they have a flow limiting stenosis. If you drop their pressure even to say 185, if the person is used to staying like, their blood pressure is 200s generally, then going to 185 or 190 might actually worsen their stroke-like symptoms and cause hypoperfusion. So is that really a safe thing? But that's just something to think about in the future. And so now they've put a lot of these other things we speak about in the warning and precautions, not in the contraindication on the package. And so again, similar things: recent surgery, ICH, and in their hypertension, they mentioned 175 over 110, which is also, I actually don't know where they got that exact number for, but it is different than what they have in the guidelines. They have a lot of different things. Also advanced age, it's a different, we don't talk about 80 over or less, they're talking about 77. I mean, there's some literature showing that patients who are over 70, 75, there is higher risk of, hemorrhagic conversion. So it's just interesting that they go with a different number. And there's a lot of other things. So pregnancy, endocarditis, other bleeding risks. So let's talk about the middle. Let's stick with the class 3 first, and then we'll talk about the kind of middle ground. So class 3, there was harm. This is class 3, no benefit. So there is, first is mild non-disabling stroke. So I'll talk about mild stroke extensively, so we'll wait for that. But they're saying if the patient has a mild non-disabling stroke, there's no benefit, even if it's 3 hours, 3 to 4.5 hours. For CT head, this is a bit tricky, because they say that there's insufficient evidence to really say what is the threshold for hypoattenuation. So I know our standard learning is if it's more than 1/3 MCA distribution, we think that's pretty extensive and we do not give TPA. And that's something we still follow. But this is just bringing into kind of, this point that maybe in the future things will change. But they do acknowledge that giving TPA to patients who have extensive regions of clear hypoattenuation, so there's a lot of clear hypodensities, these patients might have an increased risk of bleeding. They have a poor prognosis. So that is something to think about. But it's really like, it makes me think that in the future, maybe we'll not go with this. Maybe there'll be other guidelines. But right now, the CT head thing is sort of goes in the no benefit category. I have this patient. He is about 95, like 90 something. He has not a great MRS, but I don't want to use that part. I just want to show you the scan. So he presents within the time window. He has NIH of more than 20. He has global aphasia, right hemiplegia, like a left MCS syndrome. So he's within the time window, within the 3-hour window. Looking at the CT head, would you give TPA to this patient? And I just wanted to see if anybody wants to put it in the group, or just wanted to get a sense of yes and no's. Sergey, I don't know if you can see if anybody writes anything, or I have to take a look at that. Okay, anybody wants to?
Can you see the chat, Dr. Mishra?
Yeah, now I can see it. Okay. Okay, so it looks like most people so far are saying no, 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 not for me. Risk of hemorrhagic rate, no, no. Okay, so right, so just to make sure everybody sees this, so we have a CAT scan. This is axial CT head, no contrast, and right here, so you see a hypodensity almost, but I don't have all the various images, but you can really see the ischemic changes, right? So it's like there's some in the temporal lobe, there's also frontal lobe involvement. And if you know, in this patient going up and down, you could actually see that this is a patient who has more than 1/3 MCA distribution. So we did not give TPA to this patient. His aspect score, which is a score that tells us if there are early ischemic changes. I'm looking at his whole CT, was very low. It was 2. So 10 is good, means those 10 areas we look at in the MCA are intact. 0 means the worst. So 2 is bad. Generally, we say less than 6 is bad. So his was 2. So based on just, even if we didn't know what an aspect score is, just looking at the CT, we could tell that the patient has more than 1/3 MCA stroke, and we did not give TPA to this patient. Great. Okay, so let's talk about the class 2, because I just want to bring up some points of discussion, because I feel like I'm sure this is what everybody sees in their regular practice too, and sometimes we're not sure, you know, what to do with these patients. So first one is mild. This is a big topic recently. So I just want to bring up the guidelines first, and we'll talk about why they're saying what they're saying. So mild strokes. So patients who are eligible otherwise have mild but disabling stroke symptoms. IV Alteplase is recommended within 3 hours. This is a class 1 recommendation. Same category, but within 3 to 4.5 hours, 2B. So it means like it's reasonable to give it to them. And then they say a mild non-disabling. It's not recommended within 3 hours. And again, not recommended in the extended window. And it's clear no benefit. And this was a new recommendation from the last update. And this was updated in 2019. So, but if I read this, to me, it's a challenge. It's like, okay, who's going to define these words for me, right? That's the challenge. Is there a difference? Is there a dictionary I can use for this disabling versus non-disabling? Because that's really sort of the clincher, right? So let's see if we can figure something out. So first of all, like, what is the background of all this? So again, there's a lot of data in stroke. Just wanted to talk about a little bit. So there's been a lot of analysis of patients who had mild stroke from the original NINDS trial, the international stroke trial, lots of different things. And it was not clear if there is a benefit for IV TPA in these patients. There was benefit in some studies if you analyze them, some not. Then as time kind of passed, you know, they looked at more data, and even looking at kind of real world data. This is the Get With the Guidelines registry from the American Heart Association, where all the stroke patients go in, like all our stroke centers put in the information. There was about 34, I think it was a little bit less than 34,000 patients. And it showed that they had good functional outcomes, mortality, and risk of symptomatic ICH was also mild. And this was good in the patients who had like within the 3-hour window and the extended window. And it also kind of brought, and again, all of the studies show the same thing, that we talk about mild disabling, non-disabling, or just talking about mild strokes. But in this registry, almost like 30% of the patients could not ambulate independently, even though they're considered mild at discharge. Almost 30% could not go directly home. 73% had a length of stay more than 3 days. So it tells us that, okay, well, we're kind of building this theory that this mild might not necessarily translate into mild for the patient. So maybe this is something that they would benefit from TPA. And so when you look at all the studies putting together, I think over time it does show that there is some benefit to giving TPA to these patients. So, and I just put some of the studies, but there's a lot of studies on this as well. So what was decided, okay, let's just do a randomized controlled trial. So this is the PRISM study. It came out recently, like in the last few years. It was, the point of this was to take mild, again, non-disabling patients. So we have patients who have NI stroke scale of 5 or less. They are considered non-disabling deficits by a clinician. And they're comparing aspirin versus TPA in these patients. So what the study was actually had to be terminated early because they could not recruit as their goal. So it was really terminated early. So it's not great, but from what they could see, there was no benefit of treatment within the numbers that they saw. And these were patients who were treated within 3 hours. So we're just looking at our standard window, not even the extended window. So just some details if you're interested, but their goal was 948 patients, but they got much less than that. This was all, I think it was all US, yeah, US patients. This was in 2014 and 2016. They wanted to look at the difference in the favorable functional outcome, which is again that modified ranking scale we spoke about, which is 0 to 1. 0 is no deficits, doing everything normal. 1 is very mild symptoms, but still doing everything as they were before the stroke at 90 days. So again, unfortunately, the study was terminated early, and that's kind of it. But some data that I found interesting was, so 281 patients completed trial. The median NS stroke scale was 2. So remember, it went from 0 to 5, and 2 was the median, and it treated them within 2.7 hours at median. And what they found was that in 90 days, from whatever data they could analyze, that 78% in the TPA group versus 81.5% in the aspirin group achieved a favorable outcome. So, which is not showing any superiority. And in terms of bleeds, again, they had like 5 Alteplase related versus 0 in the aspirin related. So based on this, there was really no benefit to treating patients with mild non-disabling stroke-like symptoms. So based on this, the guidelines were updated to say that patients who have mild non-disabling stroke, there's no benefit. But I just wanted to go into a little bit of details of that. So after this came out, again, we had 2 big trials that came out, which are kind of in the mild stroke world as well. And I think it's important to bring them up, is point and chance trials. So we spoke about giving TPA to mild stroke, but then, well, someone said, how about just giving antiplatelets to mild stroke? Let's do dual antiplatelets versus single. So this is a new recommendation, class 1A from AHA-ASA, based on point and chance trials. And so let's just go into those quickly. So the point trial is North American, Europe, Australian trial, and they took patients who have minor ischemic stroke, NIH less than 3, or high-risk TIAs. There is the ABCD2 score, which we use, more than 4. And they took these patients and they gave them aspirin versus aspirin and clopidogrel. The patients who got the dual antiplatelets, that was for 3 months. And they looked at the outcomes, various things. So in the composite outcome in 90 days, they had, which is everything, ischemic stroke, MI, death, that was less in the dual antiplatelet group, 5 versus 6.5%. Even ischemic stroke was less on the dual group, 4.6 versus 6.3. And major hemorrhage, of course, was more in the dual antiplatelets versus a single antiplatelet. Patients were not eligible if their TIA symptoms were limited to isolated numbness or vision changes, dizziness, or vertigo. And again, that's kind of important. So let's go into chance and then we'll talk again. So there is a chance study. It's similar. It was a Chinese study. And again, NIH less than 3 high-risk TIAs. In this case, they took patients and put them on aspirin clopidogrel for 3 weeks. And they saw again similar, that the primary outcome of stroke at 90 days was much less, 8.2 versus 11.7 in the aspirin versus the dual antiplatelets group. And then the hemorrhage was more than patients. Sorry, in this case, the hemorrhagic was similar. It was 7 patients versus 8 patients in the dual versus single group. So, second. And this is an analysis of the two studies, a very nice paper in JAMA Neurology, which is pretty much showing you that, my screen is, okay. So this is time since randomization. This is in weeks. If the curve is up here, it favors dual. If it's down here, it favors aspirin. And this is hemorrhage, this is stroke. So as you can see, as time passes, so around like week 4 or going forward, the benefit of being on dual for ischemic stroke prevention decreases. So based on the two studies and this analysis, currently, the recommendation is, which is a new recommendation, the patients with minor NIH less than 3, high-risk TIAs, dual antiplatelets with aspirin and clopidogrel should be initiated and can be continued for 21 to 90 days. So what's interesting is, again, both these studies excluded patients who got thrombolytics, they excluded patients who had endovascular therapy. Secondly, in this case, they do not really say what clinical deficits were seen in these patients. So they are less than 3. So they, again, did they have mild, like, did they have more aphasia? Did they have more numbness? We don't really know. But this was a study where they were really also looking at non-disabling stroke, but it's not really defined. And again, we don't have data or like details to see how many patients had what exactly. So that is kind of interesting. And then, sorry, let me go back.
Oh, fuck.
All right, sorry guys, this is, okay. So based on that, the question is really that hopefully is arising in your mind is that, okay, what is disabling? You know, what does this mean? Because these studies are not describing it. We don't really know. We're asked to use our own clinical judgment. So what do we do? And at the end of this talk, we still don't really have an answer, but I wanted to see what everybody was thinking. So I wanted to give you a couple of cases and please put in the chat. So if you have a 53-year-old female, pre-modified ranking is 0, which means she's fully functional. She comes in with expressive aphasia. NIH stroke scale is 2. No focal weakness, numbness. Would you give tPA? These are all like real cases I've had. So I see Dr. Wong saying yes. Dr. Pavlitzak is saying yes. Okay, everybody's now saying yes. Okay. So it looks like most people are saying yes. And I suspect it's because of the actual deficits. It says expressive aphasia. So this patient we did give tPA to, and she couldn't undergo MRI because of some metal issue, but she had a couple of CT hits which did not show any obvious stroke, but clinically it was very obvious that she had expressive aphasia. And when she left, her NIH was 1. So her aphasia had improved, but it went from 2 to 1. And her MRS was 1, but she was able to still function despite having the aphasia. Okay, looks like we're all agreeing. This is second case, 35-year-old female, again, pre-MRS is 0. She has right limb and facial weakness and numbness. So she has right-sided limb weakness, facial droop. She also has numbness. NIH is about 4 when she comes in. So we do the CT head. Now the NIH stroke scale is 1. And she just has numbness on the right. Would we give tPA in this case? Looks like most people are saying, most were saying yes. Some people said no. Most people are saying no. Okay, no. All right. So symptoms are improving, so no. Okay. So yeah, so this is exactly, I mean, kind of what happened to this patient. It seemed like she had, somebody said yes, okay. So she was improving after the CAT scan. Seemed like, okay, well, maybe it's just the numbness. We're still deciding, you know, talking to patient, family, that kind of stuff. And then so we said, okay, while we're doing all this, let's just get a CTA head and neck. And after, I should have said CTA. But after CTA, like the whole CT-CTAP is done, we have an NIH is 1, numbness on right, and there's no scorable weakness on the NIH, but she does have about like 4 out of 5, almost 5 minus, like very mild weakness on the right side on the limbs, like elbow extension, hip flexion. So this was your scan, sorry, this was your exam after the scans are done. Are you going to give this 35-year-old TPA or not, even though her NIH is 1? So mostly no, I see. Depends on CTA. So she did not have a large vessel occlusion. She had no flow limiting stenosis. Her perfusion did not show any obvious perfusion deficit. I see a yes. I see a no from Dr. Machadan. Okay. So mostly looks like no. We'll also get MRI. Okay. So kind of in the middle, it sounds like. So this is a, I mean, in this case, I guess I personally dealt with it differently. So because she still had mild weakness on that right limb, and again, for me, that is disabling to a 35-year-old who's fully functional. Even the numbness actually, I mean, I would consider disabling if the patient considers disabling. So the numbness, she didn't really bother her much when we spoke to her, but when we re-examined her, she did have some weakness, and speaking to her, it did sound like that was bothering her. And plus, as even objectively mild weakness in a 35-year-old, I would consider that disabling. So we actually offered her TPA. We had a whole discussion with her and her family, and she is the one who said, you know, she doesn't want it because she thought she was getting better. So in this case, we, as me and our team, we did offer TPA because we did think her symptoms were disabling. So, okay. So she did not get TPA because she did not want TPA. She did have MRI confirmed infarct. I believe it was in the left corpus callosum and maybe in the frontal lobe more medially as well, I think. But she definitely had an infarct. NIH was 0, MRS was 0 on discharge. She was treated with antiplatelets. And this third case, which I got when I was a fellow, and I learned from it myself, was a 70-year-old male, multiple vascular risk factors, like everything in the book. Pre-MRS was about 1 to 2, has some dizzy, and presents with dizziness, unsteady gait. NIH was 0, but he has gait ataxia on exam. So would you give TPA? I see Dr. Levine said yes already. Okay, everybody's saying yes. Okay, would at least offer it. Okay. So this is a case I learned from personally. This was when I started my fellowship, like very initially. And my thinking was, well, I've been taught NIH is 0. It's you know, he doesn't really have any deficits. So I did not offer him TPA. But then, of course, my attending spoke to the patient and, you know, went with that. But I personally did not think he would get TPA. But I learned from that because I completely agree that if somebody has gait ataxia, he probably has a cerebellar stroke. Despite having an NIH 0, you have to consider that as disabling. And in this case, I don't think he received TPA by the time because he actually improved by the time, like, you know, a few people talked to him. But this is a case for, I think, everybody that if they have gait ataxia and it's considered disabling, you really should offer it. So what is considered disabling? This is from the PRISMS. This is how they describe it. The clearly disabling deficit was defined as a deficit that, if unchanged, would prevent the patient from performing basic activities. So pretty much ADLs or returning to work. And in this case, again, the local clinicians decided. So it was based on their judgment. And they also said that in this case, if the patient did have disabling deficits like limb weakness, aphasia, visual field, even if the NIH was less than 5, they actually did not put them in the study. They were excluded at the time of randomization. So just for our trainees, you know, what is considered non-disabling? Typically, it is pure sensory symptoms, isolated ataxia, isolated dysarthria, isolated facial weakness. However, you have to speak to the patient. If numbness might be very disabling to a 20-year-old. A facial droop will be disabling to maybe even an 80-year-old if they're fully functional. So we do have to keep this in mind, but really have the discussion with the patient. There's really no clear consensus. The other thing we have to remember is mild symptoms can also have a large vessel occlusion. Up to 20-30% of these patients can have a large vessel occlusion. They might have just good collateral. So that is something also to think about, that you don't want to say, and Dr. Parmatzakis is bringing up a very good point, that NIH stroke scale does not account for posterior circulation exactly. So that's why we have to be very mindful of that. So patients who have ataxia, dizziness, other things like that, they might all still have a posterior circulation stroke. So no consensus really, but it is something that I think we all deal with a lot. So I think the lesson of the story is that you really have to speak to the patient and see what's disabling for them. So a few other things to talk about indications. So patients over 80, that's something that we always talk about. If they are within the 3-hour window, it's easy to give them TPA. If they are, what if they're in the extended window? So in the past, it used to be, oh, it's a contraindication, but recently it's become a class 2A. So it's reasonable to give these patients TPA. It can be safe and as effective as in younger patients. I could not find a recent case, but I personally have given quite a few TPA patients in this category, along with I think our stroke colleagues as well, at least Maimonides. And we do know older patients have poor outcomes, higher mortality, higher rates of symptomatic intracranial hemorrhage, but it does provide a better chance of being independent at 3 months across all age groups. So this is based on a lot of, again, retrospective analysis, analysis of the various trials, because a lot of the trials excluded patients who are over 80, but there are at least, I believe, 3 of the big stroke trials did have a lot of data. And based on that, we do know that they have a better chance of being independent. So Alteplase across all age groups. Pre-existing disability, we discussed this a lot because you have a patient with MRS of 4 or 5. Do you really give them TP or not? So it does increase the risk of symptomatic intracranial hemorrhage, and it might really give great benefit for improvement, but it is something, again, that is reasonable. So again, it's a class 2. So what it's saying is don't exclude these patients just because they're pre-existing disability. They have pre-existing disability. Seizure, something we always discuss because we do get patients come in seizing, now they're postictal, could be a stroke. What do we do? So again, it used to be an absolute contraindication a while ago, but now things have changed. It's really sort of relative, because it's reasonable in a patient with a seizure at the time of onset of acute stroke if you think that the residual impairments are secondary to stroke and not a postictal phenomena. So this is all great to hear that, but honestly, it's very hard to do this, right? Because by the time you wait for somebody to resolve, it might take hours, right? So patients who are postictal, they could be postictal for hours, for days. So of course, you don't have the luxury of that time. So what I personally do, and I think probably a lot of people do, is that get a CT angiogram, get a CT perfusion. If it does look like somebody with like a large vessel occlusion clinically, then you really should have a large vessel occlusion on the CTA. If you see a large vessel occlusion on the CTA, it's helpful. Then okay, well, it could be that the patient has a stroke and a seizure, but the patient is probably also having a stroke with this LVO. So we would go ahead and give them TPA. So this is honestly, seizure at onset is very challenging. But we do know that rate of symptomatic intracranial hemorrhage and stroke mimics, including seizure and migraines, conversion disorder, is actually very low. Some studies have reported as low as less than 1%. So if you do think the patient, you're not sure, maybe it is a stroke, then you can be rest assured the risk of bleeding is actually low. Cortical microbleeds is like upcoming topic. We don't have enough data yet, but what we know so far is that, first of all, you do not need the MRI to exclude cerebral microbleeds before you, sorry, this should have been cerebral, not cortical, to exclude cerebral microbleeds before you give TPA. Why is this important? Because, we do have patients sometimes with history of severe hypertension, and they might have multiple microbleeds. So the question is, does that portend a high risk of intracranial hemorrhage? So there's been some studies which shows that maybe if these patients have more than 10 microbleeds, they have a higher risk of hemorrhage. So again, this is class 2, we're in class 2. So patients who previously had a small number of CMBs, which is less than 10, you can give TPA, it's reasonable. But if they have a high burden, more than 10, it may be increased risk, associated with increased risk of hemorrhage, and benefits of treatment are uncertain. So it's very rare that we have somebody who we already have MRI. I think recently we had a case where they were here before we had MRI. We saw they had a lot of microbleeds from before, more than 10 for sure. So we did not give the TPA. But it's rare to have somebody with MRI before. But so you do not need the MRI, but someone comes in, they say patient has known amyloid angiopathy. You think maybe they have a lot of microbleeds, then maybe you should not give that patient TPA. Again, so the numbers are all over. They're common in patients. So receiving IV Alteplase, the CMB is 50 to 27%, but patients who have more than 10 CMBs, the risk of symptomatic intracranial hemorrhage is higher. But this is, again, based on limited case series. We do not have a randomized control trial. So this is probably going to be an upcoming field in the future, but just something to be aware of. GI-GU bleeding. So there is literature and more case series showing that there's a low bleeding risk with IV TPA in the setting of recent or past GI-GU bleeding. So GI bleeding within the last 14 days is a contraindication, but they've actually removed GU bleeding from the contraindication now. So again, it might be reasonable. So recently, I think a year ago, we had a case with somebody with history of GI bleed, but we looked at risk versus benefit, and the patient had significant deficits. So we went ahead and gave the lady TPA. So you have to look at risk versus benefit in these cases. Pregnancy, it's a whole category. But I just wanted to bring it that what the guidelines say is that it may be considered in pregnancy if benefits of treating moderate to severe stroke outweigh the risk of uterine bleeding. So the best guidelines we get for pregnancy are from the Canadian Stroke Guidelines. So they say that reasonable to give IV Alteplase to a pregnant woman who otherwise meets the criteria, but you have to have this with their whole team, including maternal fetal medicine, OB. Like this has to be a combined discussion with OB. Good thing is that TPA does not cross the placenta, and we don't think it's going to be harmful to the fetus. However, the concern is that maybe it'll increase the risk of uterine bleeding, maybe it'll increase the risk of symptomatic intracranial hemorrhage. What's important is that it is reasonable to forego IV Alteplase for a woman with known LVO. So what this is saying is that, say a patient comes in, they're in window for TPA, you find that they have a large vessel occlusion, then it is fine to leave the TPA and just take the patient directly to the cath lab. And again, in discussion with the patient, the family, as well as OB. Cardiac, just wanted to bring up MI. So I personally had a patient a few months ago, and I wasn't sure what the current guidelines are, and was sort of in the middle because, again, it's reasonable. So there are patients who have acute ischemic stroke and acute MI. If they're having acute MI, then it's giving TPA and then sending them for angioplasty is reasonable. If they've had a recent MI, again, it says reasonable. So the patient that I had I think, a STEMI recently, and then looks like subcortical stroke. And so we consulted cardiology, we discussed with them properly, and we came to a conclusion that we should not give TPA to this patient. Secondly, if you give TPA, you have to stop the antiplatelets for 24 hours. And the patient, I think he did have a stent as well. The concern is not so much for intracranial bleeding if you give TPA, but it's more for things like cardiac tamponade, rupture. There's been cases case reports where a patient has STEMI, they got TPA, there's a higher risk of cardiac tamponade in those patients. Just a couple other things. So this is something we always get, patient who has an angiogram and they have stroke, what do you do? So it's reasonable to give these patients TPA. I had this patient, 60-year-old female, pre-MRS 0, had an angio. She had to get rule out AVM, which was ruled out. Starting to develop expressive aphasia, maybe very mild right side weakness. Would you give TPA? I did. So I don't know if anybody wants to put it in the group, but it's reasonable. She's having disabling deficits. So we went ahead and gave her TPA and she did fine. Other things to just know is that if somebody has an aneurysm, generally if it's less than 10 millimeters, it's reasonable. If somebody has had, like a lumbar puncture in the last 7 days, it's reasonable to give TPA. So I do realize I'm pretty running late. Sergio, do you want me to continue for a few more minutes or?
So we're gonna have some time for questions, Dr. Mishra. So if you want, you have like a few slides that you consider important, or we can go straight to the questions.
I just wanted to talk a little bit about maybe like for MRI and wake-up stroke and just the TNK. I just wanted to mention about TNK.
That sounds good. So we can do like a quick review.
Okay, so just want to talk about wake-up strokes. Again, this is upcoming. It's not being done everywhere. So you can take the diffusion weighted imaging, compare that to the flare sequence, because it's believed that it takes up to 4.5 hours for changes on the flare sequence to show up, but they can show up as early as 30 minutes on the DWI. So taking that mismatch which says, hey, it's on DWI, but not on flare. So the patient is in the acute window. So we're using a tissue window rather than time window. So now there's new guidelines, again, class 2A, patients who wake up with symptoms of stroke, or they are more than 4.5 hours from their last known well. If you use the MRI mismatch, DWI to flare, it is reasonable to give them TPA. I will not go into the studies, but we did start doing it at Maimonides ourselves. We gave the first one last year sometime. So this was a patient, 64, pre-MRS is 0, NIHP TPA was 1. She did not have LVO. And this was the DWI, this is the flare. So right here in the left frontal, like white matter, you see the signal, but it's not on the flare. So we consider this DWI flare mismatch and we gave her TPA. And I mean, to begin with, the symptoms were mild, but the patient had the same exam when they left, 1 and 1. But when we saw the patient 30 days, they were 0, 0. So we have started doing this. I think we've done 4 or 5 cases in Maimonides. And this is a patient we did not give TPA because it's on DWI. This is the posterior limb of the internal capsule. And it's on the flare too. So we did not give TPA to this patient. And then we have a protocol for stroke code, and we've added wake up to that. We're currently working on a protocol to standardize this and have a policy. Tenecteplase, it is a modified variant of, when I say ALT, that's Alteplase, it has a higher fibrin specificity, and it has a longer half-life. So it can be actually given as a single bolus versus a whole infusion for an hour for Alteplase. And it is established treatment for cardiac issues, MI. So the study Extend IA TNK, which came out in 2018, which took patients and gave them TNK versus TPA before thrombectomy. So these were patients who had large vessel occlusion. And what they noticed in that before the patient went in for, so they had the angiogram. At the angiogram, patients who had more than 50% of reperfusion, 22% in TNK and 10% Alteplase. Also their functional outcome, the MRS was 2 in the TNK and 3 in the TPA. So what it's showing is that it's non-inferior to TPA. So again, there's more studies come out of this. The issue with TNK is there's multiple doses, 0.1, 0.25, 0.4. I believe MI, they use 0.5. So this study used 0.25. So based on that, the new guidelines say it may be reasonable to choose TNK over Alteplase in patients who are also eligible to undergo mechanical thrombectomy, because remember, these patients actually were undergoing thrombectomy. And there's another dose, but they go with 0.25. So what does it mean? Many institutions have replaced the Alteplase with TNK. You might have heard of that. We're working on a policy and a protocol right now at Maimonides. Probably by the end of this year, we'll be able to implement it. We did a small survey just within our hospital, a very small, not many people. I think it was 19 or 20 responses, just from ER stroke pharmacy, just to get a sense of what people are thinking. And interestingly, 58% said that they would add TNK to our formulary along with Alteplase. Only 6% said they would replace it. And then interestingly, the question always arises, do you tell the patient, hey, this is off-label? How do you approach this? What is the legality of things? So almost 80% of the people say that they would inform the patient that TNK is being used as off-label. But this is, again, upcoming. You'll hear a lot about it. There's not enough, I mean, we do have people who are convinced, we have people who are not convinced. So there's obviously a lot more research to be done, but it is something that you'll be kind of seeing and hearing more of. I just wanted to bring this, if this would be helpful to anybody. We use it at Maimonides. How do you, kind of approach acute stroke? So you have the 6 hour, 6 to 24 hour window, more than 24 hours, and NIH strokes more than 6. You're looking for cortical signs or brainstem signs. And so here we do this, we activate a stroke code. If this is what we see, if it's more than 24 hours, we do consult. And then this is, if it is a stroke code, when you order CTA perfusion. So of course, any suspicion of LVO, but generally if the patient NIH is more than 6, there are persistent cortical signs, there are brainstem and cerebellar signs, suspicion for vascular dissection. Out of them may benefit from CTP-based TPA treatment. So it's not something we're doing right now. That's a whole topic. I didn't mention it, but there has been a study which has used CT perfusion to give TPA. I don't think any of the 3 hospitals are doing that, but that is something that might happen in the future. So these 2 is what we follow at our hospital. This is courtesy of Dr. Jin and Wang. That's it. Thank you.
Thank you, Dr. Mishra. It was a really nice presentation. So I think we had space for a couple of questions. There is something already in the chat. Dr. Mishra, do you want to read that question?
Oh, so I think the last question I see is, are all GI malignancies absolutely contraindicated for TPA? That's a good question. So the way, I mean, it's in the guidelines, and from the literature, they just mention like if it's a solid malignancy, but we don't really know the answer, what kind of malignancies are absolute contraindication. And it is really recommended to speak to GI and actually have this discussion with GI when you're thinking of giving TPA to this patient. But to be cautious, if the patient has a GI malignancy, we're not sure what exactly it is, what's the risk of bleeding from that, then I would recommend not to give TPA.
Okay, maybe we had one more question.
So Mishra, thank you for this great lecture. You mentioned the contraindication for TPA within 3 to 4.5 hours based on the ECAS-3 trial. However, there has been some information from the Get with the Guidelines that these exclusion criteria may not be valid. Do you have any comments on that? Like history of diabetes and stroke, age more than 80, and that sort of thing.
Absolutely. So that's a very good point, because since then, ECAS-3 was a while ago, many years ago. There has been like more analysis, there's been like more case series, and looking at it, actually patients who have diabetes and prior stroke, it does look like it might be safe to give them TPA. And I didn't touch upon this, so I'm glad you brought it up, Dr. Marshanan, that if you look at the guidelines, now they say that patients who've had diabetes and stroke, who have the high NIH in that extended window, it may be reasonable to give them TPA. So those limitations that came out of ECAS-3 a long time ago are, again, slowly, like, things are changing. And I suspect personally that a lot of these kind of indications will eventually just become, you know, clinical judgment, and maybe eventually we'll start giving more TPA to these patients. But right now, yes, all those exclusions from ECAS-3, most of them have become like class 2, so reasonable to give TPA.
I see. Regarding the contraindication of prior intracerebral hemorrhage, there are different causes of intracerebral hemorrhage. For example, hypertensive intracerebral hemorrhage. If blood pressure is well controlled, would that be still a contraindication? I don't think that the guidelines make any mentioning of that.
Yeah, that's also a very good question. So again, the guidelines do not mention that, but if there was a paper, I think it came out a few years ago, which is from the AHASA, a scientific rationale for inclusion exclusion criteria for TPA. I can definitely send it to everybody. So that is a very nice paper, which actually talks about all these relative contraindications. And it does touch upon that, yes, you have to look at the cause, which is that if, say, the patient had like traumatic subarachnoid because of they fell down, and since then they haven't had any falls, and they have really no reason why they would have a recurrent bleed, would you consider giving TPA to that patient? And then you mentioned hypertension. So they have very well controlled hypertension, one bleed. Should that patient really be excluded from TPA? So that is definitely a topic, which is also sort of, you know, a topic of discussion these days. And it has been something that I think they're going to look at, and maybe eventually, like, that will also be something that will change. I personally, I think I was almost about to give TPA to a patient who had a subarachnoid like 15 years ago, and had definite trauma, hasn't had a fall, and was having, you know, pretty moderate stroke-like symptoms. And because, you know, I said, well, this is kind of the fact that he had this ICH long time ago, there was a reason for it, but I did not, because he improved. But I think I agree with you. I think this is going to become also sort of a thing that we you know, start giving more TPA to these patients.
Okay, very good. I have a few more questions, but I think in the interest of time, one last question regarding the aneurysm location. I was thinking about this, and I think it matters if the aneurysm is within the ischemic region versus if it's not. Let's say you have a basilar aneurysm and then MCA stroke. TPA might not affect the aneurysm, but if the aneurysm is within the stroke area, it might actually be damaged by the stroke itself. So what do you think of this?
Absolutely. Again, very good point. If the aneurysm, even though it's small and it's within the ischemic area, yes, it might have a higher risk of hemorrhage. And I, again, agree with you. I might not give TPA to that patient, even though it's a small, like a 1 or 2 millimeter aneurysm. The issue is that we, again, do not have enough data to definitely say we should go this way or that way. But we do know if you have a very large aneurysm, like more than 10 millimeters, then the risk of rupture is higher. Secondly, if the other thing is that, say, if it's a small aneurysm, but it's in a location in the posterior circulation, so PCOM, PCA, which have a higher risk of rupture, even though they're small, would you really give TPA to that patient? So again, that whole discussion with risk versus benefit comes in again. So I don't think we have an answer. I think at this point we have to use clinical judgment.
Right, especially because we're using this hypertensive, permissive hypertension, which might put the aneurysm at a higher risk of bleed. Thank you very much, Mishra.
Thank you.
Yeah, Dr. Mishra. Oh, I'm sorry.
I'm sorry. Can I proceed?
Yeah, just like we are not running out of time. So yeah, I think like we can, if you had a question, you can like message us and we can like provide it to Dr. Mishra. But sure. Yeah, thank you so much, and sorry for like cutting you off.
Yeah, that's okay.
But I'm gonna try to provide you with the information from Dr. Mishra. Okay.
Sure, great. Thank you.
Okay, I just want to thank everyone for joining us to the ground rounds, especially Dr. Mishra for giving us this really good lecture. And I hope to see everyone the next Friday for ground rounds. and have a good day.
Thank you, Dr. Mishra.
Thank you, everyone. Have a good day.